Okay, so this is a two-part question. What is the difference between static positional testing in a VNG and positional testing for BPPV? Part 2, and do we treat abnormal findings found in static positional testing of the VNG? Okay, so this is a really important distinction that guides not only your interpretation of the findings, but how you approach treatment. So static positional testing in a VNG refers to slow positional testing. The key word here is slow. We're not trying to identify BPPV that typically requires faster dynamic movements that are done separately in the VNG. Instead, we're looking for nystagmus in various static positions, like supine with the head supported in center gaze versus supine with cervical extension. We also test with the head turned versus full body turn to see if position alone triggers nystagmus. Now, you might see BPPV nystagmus during the static positional testing, but that's not the primary goal. We're actually looking for something different. Whether nystagmus is present just from being in certain positions, not from the movement into those positions. So what does it mean when you find abnormal nystagmus in static positional testing? Most likely you're looking at VOR dysfunction due to an asymmetry. The vestibular system is unbalanced. So when you remove certain visual or postural references, that asymmetry shows up as nystagmus. This is why the primary goal is determining the etiology. What's causing this positional nystagmus? Is it a recent vestibular loss, an incomplete compensation, or is it something more serious that needs medical attention? As for treatment, once you've ruled out serious pathology and the patient is stable and appropriate for vestibular rehab, your most likely intervention is VOR training. You're not doing canalith repositionings like you would for BPPV. You're working on improving the overall function and neural compensation of the vestibular system through gaze stabilization exercises. Here's a key takeaway. Static positional nystagmus suggests a system imbalance that needs retraining. BPPV suggests displaced otoconia that needs repositioning. Different problems, different treatments, even though both show up during positional testing.